There are a number of commonly asked questions that I've been asked, over the years. First has to relate to the processing and the handling of the samples. I think, as I mentioned before, right, one collects a peripheral blood sample, collects it in a purple top tube. Important to place it on ice immediately, and then to process it by getting rid of the peripheral blood mononuclear cells. Okay. Again, one cannot take a blood sample from a central port because that will spuriously overestimate what the 5-FU drug levels are. So one of the concerns that many of us had early on was that if the blood sample that was drawn from an individual patient was not processed in a sufficient time or in an appropriate fashion, that there could be residual dihydropyrimidine dehydrogenase. So that's DPD. That's right, as you recall, that's the enzyme that can very rapidly break down 5-FU. There are very high levels of this DPD enzyme present in peripheral blood mononuclear cells. And so as soon as a blood sample is drawn, it usually is then collected in a purple top tube. The tube has to be placed on ice to basically inhibit the activity of the DPD breakdown enzyme. And then in short order, but certainly within 1 hour's time frame, one then has to spin the blood sample to get rid of the peripheral blood mononuclear cells. Because if there are any PBMCs still present in the blood sample, that could lead to a spuriously low 5-FU AUC drug level. So the fact that only 5 tests had a drug level less than 8 tells me that actually the processing and the handling was actually done very, very well. I think the other point to emphasize is that the blood sample has to be taken from a peripheral site, because if you actually take it from, say, a central venous port, the blood sample and the 5-FU AUC drug level will be spuriously high, which obviously is not going to be an accurate representation of what the appropriate drug level is in that patient. So this next slide just shows you on the left-hand side the report that the folks at Saladax Biomedical will give to you, the practitioner, on an individual patient. And so the key thing is, if you look at, I guess, purple icon number 1, the test order. So this is my 5-FU using this 5-FU immunoassay. 5-FU, the infusion duration, the dose, and the subsequent 5-FU AUC drug levels that were measured. The target range, again, the sweet spot is 20 to 30. And then if you look at, I guess, icon purple 2, in the lower part of this panel, you can actually plot out the dose of 5-FU that was administered and the subsequent 5-FU AUC drug level. And then in panel 4, you can actually see the 5-FU AUC target range and then the dosing algorithm. So what dose of 5-FU needs to be increased or decreased based on the AUC drug level. And then based on the results of the 5-FU AUC drug levels, you can then administer your subsequent dose based on the dosing algorithm. In the very first treatment, again, only at most somewhere between 30 and 40% of patients will be in that sweet spot. And now we're looking at a sweet spot of 20 to 30, okay? But that with each subsequent cycle, and now going out to 4 treatment cycles, you can see that the splay of AUC drug levels for 5-FU actually now comes to within that 20 to 30 range. Having this broader target range, I think, allows us, the practicing physicians, to more safely titrate both up and down the dose of 5-FU to give our patients a more effective dose. How does this change the way I manage my patient? In my view, I think this is a much more effective way to administer 5-FU. One needs to monitor at least 4 continuous treatment cycles of any type of infusional 5-FU based regimen monitor that to then be able to feel like you know exactly where the individual patient's 5-FU AUC drug levels will fall out. Ideally, PK dose adjustment should be performed based on the 5-FU AUC drug levels. And I think it is clear that one dose adjustment may not be sufficient to achieve the appropriate target AUC in at least half of the cases that are seen. Test cost and potential health cost savings. So the test cost, it costs about $500 to run this sample. And I think in terms of the potential cost savings, I think already there are theoretic health economic models that have been conducted, and I think there clearly is going to be a significant health cost savings. So this is looking at patients here in the United States who are treated either with FOLFIRI or FOLFOX-based chemotherapy. And what you can see is that in patients who are receiving 5-FU using a PK-guided dosing approach, the number of adverse events, the number of complications is reduced by nearly half. And we know that those adverse events are associated with an increased cost of complications and treating the complications, either with hospitalizations or with growth factors that are pretty expensive. And I think we're going to be hearing more and more about the potential pharmacoeconomic effects of this approach in the years to come. And then finally, what about DPD deficiency? So I can tell you, because my own laboratory research over the last 25 to 30 years has been looking at thymidylate synthase. There's absolutely no correlation between the presence of mutations, the expression of thymidylate synthase, and toxicity to 5-FU. So to me, that's a meaningless test. And in terms of the presence or absence of DPD mutations, the trouble with a genetic test is it doesn't tell you whether or not genetic mutations are truly translated into defects in the function of the DPD enzyme, DPD protein. So we know that up to 40 to 50% of mutations that are identified in the DPD gene do not translate into actual clinical DPD deficiency. And we also know that maybe 50% of patients who present with what appears all the world to be DPD deficiency will have no mutations in DPD gene. So my view is that measuring the 5-FU drug levels is really the best way to actually identify whether or not a patient may or may not have DPD deficiency. You know, the general rule has been that if you have a patient with partial or complete deficiency in DPD, 5-FU should be off the table. But as Dr. Gamelin and his colleagues in France have, I think, very nicely demonstrated, even in patients who have pretty significant DPD deficiency, if one starts off at a very, very low dose of 5-FU and then subsequently monitor 5-FU AUC drug levels, you can actually effectively treat a patient with DPD deficiency and be able to minimize and or reduce the potential for 5-FU toxicity. So I actually think that having this test available might make it possible for us to treat patients who have either partial or complete deficiency in 5-FU. To summarize, you know, a lot of the initial studies were done in France, but now there have been studies done in Germany, a number of studies done here in the United States. Saladex has also partnered with folks in China and Singapore. And I think the results are very, very consistent, and they show a clear benefit of PK-guided dosing of 5-FU. There clearly is very rapid turnaround time for making clinical decisions, and using this, I think, very novel 5-FU immunoassay-based approach. As I mentioned, the turnaround time can be within a day. It obviously, I think, allows for individualized dose adjustment throughout therapy. And so as we're kind of in this era of personalized medicine, right, to give the right drug to the right patient, I think, unfortunately, what people have forgotten about personalized medicine, it also really should be, you know, the right drug to the right patient at the right time and at the right dose. And so this PK-guided dosing really fits, I think, very nicely into the whole concept of individualized, personalized medicine. And I think by being able to more carefully titrate the dose of 5-FU, that can lead to improved clinical efficacy, we can maximize the dose of 5-FU, but at the same time, we can actually reduce and minimize the risk of toxicity. Please feel free to email me directly. My email address is chue2, so that's chue2 at upmc.edu.